Hello, everybody. Very happy to be here with you at this IPOPI PID Asian regional meeting. I would have loved to be present face-to-face in Tokyo, Japan, and meeting all of you. But I think it's great that even during this COVID-19 pandemic, we can be together through virtual meetings. I hope everybody's safe, and I have been invited by IPOPI and the organizers of the meeting, whom I all thank, to give a talk on over 400 PIDs for children and adults, and how do we deal with that. I'm going to share my screen with right now. And it should be visible now. Okay, so a little bit of background. Rare disease, PIDs are rare diseases, and rare diseases means that it's a disease that affects less than one person out of 2,000 persons in the country. There are approximately 8,000 to 9,000 rare diseases, which accounts, at least in Europe, for 6 to 8% of the European population. More than half of these patients are youth, which means that they are aged younger than 18 years old. So it means also that rare diseases can affect adult patients. Usually, patients with rare diseases have multiple disorders at the same time, and it has a high impact on their lives, and they usually need different kinds of healthcare. One of the major issues with rare disease is that many stakeholders have a lack of essential knowledge on this group of rare diseases. So focusing now on what is more interesting for us today is primary immune deficiencies. So I like this cartoon because it brings together 5 of the major comorbidities that patients with PIDs might face. The first one is infections. So they might be severe, they might be recurrent, they might happen only once during their lifetime with a very specific bug, a virus, or a large broad of bugs such as viruses, bacteria, fungi, parasites. There are also immune dysregulation problems such as allergy, autoinflammation, autoimmunity. And in a certain percentage of patients, they might also face malignancy or cancer. So just to give you, some big figures, there's the European PID registry, which I used to chair a few years ago, and as of today, there are almost 30,000 verified patients. And so that's really huge, but it's also only the tip of the iceberg, because we know there are many more. And as you may know, the major PID category is the blue one on the right part of the pie chart, which is the predominantly antibody deficiency group for more than 50%. The other groups are the so-called other well-defined primary immune deficiencies, such as the Wiskott-Aldrich or the ataxia-telangiectasia or the DeGeorge syndrome. The other group is the combined immune deficiencies, which are diseases that affect both T cell and B cell, and innate immune deficiency with mostly phagocytic disorders such as severe congenital neutropenia or chronic granulomatous disease is the third group. And there are a few other groups that are less represented in this registry. So CVID, common variable immune deficiency, is the first PID, most numerous PID, and that is true over the globe. So it certainly is true in Asia as well. And as you can see, the major, it's a publication that is now a little bit old, but it's on a major group of CD80 patients registered in the EASY registry, you can see that pneumonia account for the first clinical feature, along with autoimmunity, splenomegaly, which is a form of proliferation, but non-malignant, non-cancerous. Bronchiectasis is when the lungs and the bronchi get don't heal very well and get dilated, leading to superacute infections. And you can see other complications of the skin or deeper organs with granuloma, enteropathy leading to diarrhea, and also solid tumors, lymphoma, and other features as well. So you understand easily that the PID specialist needs to work with a huge range of healthcare professionals and also the laboratory. And the key word here is networking, and we do that through monthly meetings, video conferences. It's been already a while, and there are also international collaboration to get advice on what to do or how to diagnose a patient. So we are living, amazing times when it comes to genetic diagnosis, because as you can see here, when at the early 1980s, there was no genetic identification, or very low PIDs had a genetic confirmation. And now, and especially with the new techniques of genetic sequencing, which is in red here, the next, so-called the next generation sequencing, we are increasingly discovering genes leading to primary immune deficiencies. And as of today, there are almost 450 different monogenic disorders, which is one gene leading to one disease, and it's expanding. And you can refer to these two papers. I hope you can see my arrow from the IUIS. The first one is very interesting because it starts with the clinical symptoms, and it leads to offering narrowing down a panel of potential PIDs. And the other one, which is below, is more about which genes leads to which clinical symptoms. So it's a little bit of the other way around. So we can summarize the immune system and how it is affected through that slide, which shows a scale. And the classical primary immune deficiencies, which are the ones that I showed, are lead to a lower, less powerful immune system, so less powerful to fight infections. And the other is leads to a hyperinflammation, which is counterintuitive when it comes to immune deficiency, but actually it's a problem of imbalance between the effectors and the counter effectors, which is key in keeping an immune system balance. So that's why you might have autoimmunity, allergy, granuloma, lymphoproliferation, and autoinflammation. So one example is is highlighted here on this very nice slide. And if we talk about STAT3 gene, there are two types of mutation. One is called the GOF, gain of function. So it leads to high STAT3 activity, as shown here on this rare state. And you can see that most of the symptoms are autoimmune here, right? And if there are mutations leading to a loss of function, so the same gene again, you will have a whole different set of problems, mostly infections, but also other kind of disease, because STAT3 deficiency is a multisystemic disease affecting the bones and other organs. So again, as I've shown, I think earlier, PIDs are not only pediatric disease, they are chronic, lifelong, complex. They need a high level of management, and patients need a high level of care. And we need also to think about how to transition patients from the pediatric care to the adult care. And as of today, in the French PID registry, which is one of the largest worldwide, you can see that the median age of patients alive as of today is 23 years old. So it means that 50% of the patients are aged above this threshold, this median. which is very interesting. So not only pediatric. And let me show you some variables on the onset of symptoms. So age at first onset was 2 years as a median, and different kinds of symptoms were seen: immune dysregulation, infection, of course, which is the leading symptom leading to the PID diagnosis, but also malignancy. And some patients didn't have any clinical symptoms. So on the next slide, it's just a histogram. You can see the distribution of age at onset. So it's mostly pediatric, but as you can see here, some patients might have an onset, so the first symptoms of their PID after age 20, sometimes after age 40. So when it comes to clinical diagnosis, so it's usually a diagnosis made around age 6, and the delay, which is the time between onset and clinical diagnosis, is 1 year at the median. But of course, depending on the group of diseases, it might differ. And the largest delay is for CVID, obviously. And let me skip this slide. This is very interesting, I think, because as you can see, almost all PIDs that you can see in children can be seen in adults, although with a different rate. So SCID is not seen in adults, obviously, because it's severe combined immune deficiency, so it's the bubble boy disease. But other diseases are mostly seen in adults, such as CVID, but also sometimes more and more chronic granulomatous disease and CGD. But other diseases that are very well known are thought to be only seen in pediatric, but it's not true, because we published this paper a few years ago about infections revealing complement deficiency in adults. So when you have a meningitis or a pneumonia or other kind of severe infections, please think about complement deficiency. What about treatment? So coming back to the European Society registry, you can see that Ig replacement therapy accounts for a huge number of patients. Of course, not all patients with PID, it's approximately 50%, and it's approximately half and half sub-Q, with a little bit more sub-Q and intravenous. And patients do that at home, because sub-Q is usually at home, but also patients do that in the hospital. Newborn screening is instrumental in improving the diagnosis rate of patients with combined immune deficiency, and especially the severe combined immune deficiency. And it leads to better survival, better outcomes. We hoped that it leads to improved quality of life. And what we want to do and strive for is improve all these parameters, but also the socialization and the well-being of PID patients, as we want them to be fully active citizens contributing to society. Thank you for your attention.